serving children with developmental disabilities and behavioral health diagnoses. How are we doing in Georgia? A project by the GaLEND 2013-2014 cohort.
We first met, Roy, he didn't have a lot of aggression or anything. He would get upset and fuss and argue. In the beginning, did not run for quite a while, but then now when he gets upset, Roy gets real mad and angry, and he'll run from the house, and he'll like run down the highway. He doesn't care if he has proper clothes on, if it's winter. If when he's upset, he just goes. And takes several hours, and then like, he'll just calm back down, and then he's sorry, and he wasn't going to hurt me, and he loves me, and those kind of things. And he'll tell you, Mama was never going to hurt you. And he doesn't feel that way at that point because he's calmed down. But when he's upset, he will hurt me. Response from the community has been tragic at times. People in the community, like when you come to church, when you bring them to church, I mean, they're scared for Roy to go in their Sunday school class with them or go on a trip, with them or anything. So you get different responses in different ways. Some people are so willing to help, it's unreal, and then other people are scared. Contacted to try to get help. I've never had anybody to be ugly to me. I've always had people to listen to my story and to try to give their advice. People's always understood my, when I would be scared or whatever, to lay down in my own home or be scared to go do things. People's always listened and understood, but not anyone's ever really known what to do to help me. The most help is going to be from Miss Susan from the wraparound services, them coming out and helping. Susan was able to help me a lot, find out what was out there, teach me. There's not a book anywhere that teaches you, okay, this is what you can get, this is what you need to fill applications out for. You don't know what's out there, and I've had to learn. But Miss Susan and them were very, very, very knowledgeable of that, and they've helped me in many ways. So, and then my Medicaid waiver, it's going to be a lot of help now. But up until I got that, the actual just Medicaid wouldn't pay to house us in a hospital for very long, 2-3 weeks at the time. And with children that has problems like Roy does, the honeymoon period's not over in 2 or 3 weeks' time. Sometimes it takes a month or sometimes even 3 months for them to realize, what's going on with Roy. I'm sure that we're going to have an outburst or two. I'm not crazy and think we're going to come home and not have any. But I hope we have a lot less, and maybe we've been trained some, and maybe that he's been trained some to de-escalate before it gets really bad, before he runs or, whatever. Or tries to, hurt me or get aggressive with me. My advice would be to go to your local DFACS office. If you have a sunshine house in your town, go to the probate court. Go to places and tell people what you need, or ask them what services are out there for you. Go to your doctors. and ask questions. Ask them what's out there, how to help.
The 2013-2014 Georgia Lynn cohort was charged with learning more about the state of Georgia's response to children with both a developmental disability and a behavioral health diagnosis and their families. The cohort consists of 17 students, professionals, family members, and self-advocates, representing a wide range of related disciplines such as social work, psychology, public health, speech-language pathology, physical therapy, and special education. Utilizing a participatory action research approach and appreciative inquiry interview techniques, our team collaborated with leadership at the Georgia Department of Behavioral Health and Developmental Disabilities, which we will refer to as DBHDD, and engaged a wide array of stakeholders who represent state agencies, service providers, and families, and all were able to describe important barriers and opportunities to change. Also, research was conducted in an effort to identify best practices in Georgia and around the U.S., and we discovered that there are a number of strategies and models that can create positive change. A problem statement was used to frame the scope of the project and assist with forming project goals and activities. Subsequently, an outline of the scope and objectives of the project were developed and were shaped by the following questions. 1. How many families in the state of Georgia are eligible for public services and qualify as having both a developmental disability and behavioral health diagnosis? 2. What are the available services and supports in the current system of care for families with school-aged children with a developmental disability and behavioral health diagnosis? 3. What are strengths of the current system? 4. What barriers to access the current system exist for both families and providers? 5. What changes might be made to the system of care in order to foster improved outcomes for these families? Georgia is home to many families dealing with the complexities of caring for a child with both a developmental disability and a behavioral health diagnosis. To the dismay of many, our state has a system that is fragmented and fraught with restraints that inhibit well-meaning providers from adequately supporting families. The opportunities described in the following slides are first steps towards the creation of a system of care that will serve children and adolescents with both a developmental disability and behavioral health diagnosis and their families. These suggestions were developed to be family-centered, community-based approaches to responding to the needs of Georgia's children and families who live with a special set of circumstances. Throughout this webinar, we hope to clarify definitions and terms, highlight the prevalence of the issue, illustrate the current system of care, provide an overview of strengths and weaknesses, and conclude with recommendations for how to maximize resources within our state's system of care. One issue that became apparent from the start was a discrepancy in the use of the terms developmental disability and behavioral health diagnosis. Determining that a person possesses a specific disability can be difficult if language does not align with common diagnostic criteria. And often, such differences in language impede a person from being eligible for services as determinations of how dollars will be distributed are based on regulatory language. The two slides that follow will delineate the differences between the federal definition of developmental disability and the definition utilized in Georgia. The federal definition of developmental disability as detailed in the Developmental Disability Assistance and Bill of Rights Act of 2000, the DD Act, is as follows. A severe chronic disability of an individual that is attributable to a mental or physical impairment or combination of mental and physical impairments, is manifested before the individual attains age 22, is likely to continue indefinitely, results in substantial functional limitations in 3 or more of the following areas of major life activity: self-care, receptive and expressive language, learning, mobility, self-direction, capacity for independent living, economic self-sufficiency, and reflects the individual's need for a combination of sequence of special, interdisciplinary, or generic services, individualized supports, or other forms of assistance that are of lifelong or extended duration and are individually planned and coordinated. Comparatively, in Georgia, eligibility for services and supports through developmental disability waivers requires that a person meet the federal definition and have an intellectual disability. This means that a person could meet all of the criteria for waiver services according to the federal definition and still not receive the waiver in Georgia if an intellectual disability is not present. For persons in the U.S. with a combined developmental disability and behavioral health diagnosis, we found that approximately 20% of children with a chronic condition also experience mental, emotional, and behavioral problems. The largest age group impacted are those children ages 9 to 17. In total, this is 4 million children in our country. Yet, there is still much more we need to know to be able to respond to the changing and future needs of the population. While we have not had the luxury of large cohort studies in Georgia, we do know that our state agencies provide important supportive services to families whose children are diagnosed with both a developmental disability and a behavioral health diagnosis. With data from the Developmental Disability Division of Georgia DBHDD, we know that 673 children under the age of 21 were served with waivers last year. Among those receiving services were 82 children who received behavioral support consultation and 10 who received an exceptional rate, two common areas of support for persons with a developmental disability who require behavioral health treatment. These data help to confirm that children with both a developmental disability and behavioral health diagnosis are currently receiving services from the Developmental Disability Division of DBHDD. Data were not available from the Behavioral Health Division to allow us to provide an interagency estimate of the number of children in Georgia with both a developmental disability and behavioral health diagnosis being served between the two divisions. However, our reviews suggest that the data currently being collected by DBHDD as a whole is no more than a reflection of system capacity and not actual need. To begin to get an accurate account of the need of our state, the internal divisions of DBHDD need to align efforts to define and report services provided to this population. All this information suggests that we need to understand specific characteristics of Georgia's children with both a developmental disability and a behavioral health diagnosis. This information may already be available through agency data and/or Medicaid profiles, or may need to be collected independently. Surveys and/or interviews could be useful tools for collecting new information pertaining to demographics, as well as the needs specific to both developmental disabilities and behavioral health diagnoses, and the expense incurred by families in providing care to their children. Persons with a disability experience higher costs in health care and poorer health status as evidenced by the chronic nature of these conditions and the barriers that exist in accessing care. Families carry the burden in terms of increased cost of care and lost wages that result in subsequent loss of state revenues. See the formula here that illustrates the societal cost of dealing with a mental health crisis can easily reach $40,000 a year. This looks like an estimated $8,000 additional dollars in cost per year for families, up to a 20% decline in the mother's labor force participation. Annual special education costs of $10,830 to $30,000 per child in 2011, and total average social costs ranging from $20,000 to $40,000 a year. As a state, we are struggling to meet the needs of our most vulnerable citizens. The lack of funding and inadequate coverage to meet special health care costs compound the impact of behavioral health and developmental disability diagnosis. Imagine what this implies for Georgia's families who have a child with both a developmental disability and a behavioral health diagnosis, whose needs are more complicated than average. One important task in our process was to define the current system of care that supports children with both a developmental disability and behavioral health diagnosis. Our goal was to look at these systems from several perspectives: that of a family trying to access services, that of a provider delivering services and interacting with other providers, and that of state-level agencies providing oversight, policy, coordination, and high-level decisions affecting children and their families. We will begin to evaluate our findings utilizing an ecological systems model, which places the individual in the center, in this case, a child with both a developmental disability and a behavioral health diagnosis. The model illustrates the varying environmental systems in which an individual interacts. Another advantage to beginning with the child in the center is to emphasize the importance of looking through the lens of the child to evaluate whether or not our systems of care are being responsive to the actual needs of the child. In an effort to describe our findings, we decided to create a visual representation of some of these systems to better describe their impact on families, the level of perceived coordination between and among organizations, and potential avenues for improvement within the systems of care. While the information represented came from our analysis, not each of the stakeholders shown was interviewed. Individuals or agencies who were interviewed are delineated by a solid black line surrounding the circle. The child's family and other informal supports have a large influence on a child and their ability to access services. One of our key findings was the strength of a child's advocacy system drastically influences whether or not he or she will receive appropriate services. The family's level of education and resources can impact whether or not their child will ultimately receive services. Additionally, the resilience and perseverance of families can also influence their ability to obtain needed services and support for their children. One barrier to accessing services is an appropriate diagnosis. When a child has one diagnosis, this reality might not have a major impact. However, when a child has multiple needs, such as developmental disability and a behavioral health diagnosis, the ability to access services becomes more challenging. To go a little deeper, a child's primary diagnosis becomes a driving determinant as to whether he or she can receive appropriate services. We heard from the community that the barriers to access are due to providers' lack of training in working with the secondary diagnosis, and other times due to specific policies that limit access based on primary diagnosis. For example, a person receives services based on their primary diagnosis, which often leads to secondary issues not being addressed. This use of one diagnosis as a gatekeeper to services creates unneeded barriers to children in Georgia. The Department of Behavioral Health and Developmental Disabilities is a primary provider of state services for children with both a developmental disability and behavioral health needs. Many times, individuals have difficulty accessing coordinated services for their needs. Services are primarily siloed into one or the other, and little to no communication occurs between the two divisions. This lack of communications appeared to be a barrier to coordinated care for children with multiple needs. Our diagram illustrates how individuals and families are most often forced to seek services from multiple developmental disability providers and behavioral health providers, who function as separate entities, though there are some agencies that provide services for both. The Department of Community Health, DCH, provides funding for the Medicaid state plan and Medicaid waivers, two primary ways that individuals with developmental disabilities and behavioral health needs receive public services in the state of Georgia. Waivers are seen as a main mechanism for which children receive services. Waivers extend access to services by waiving specific eligibility criteria required to access Medicaid. Their function is to provide access to community supports that enable children to live in their community as opposed to an out-of-home placement. Individuals with developmental disabilities must reach a specific level of care required before they are eligible for a waiver. A lack of funding has created an extensive waiting list in Georgia, but discussion continues around the expansion of these services. The Medicaid state plan provides funding and policy for general Medicaid services. Children receive funds through this plan if they meet the eligibility requirements of Medicaid. If a child has a waiver, this should theoretically not exclude them from general Medicaid services. There is also much advocacy for the expansion of Medicaid in Georgia. In addition to all recipients of Medicaid services, this expansion would benefit children with both a developmental disability and behavioral health diagnosis. The Early and Periodic Screening, Diagnostic, and Treatment Program, EPSDT, is another potential resource for Georgia's children with both developmental disability and behavioral health diagnosis. Under EPSDT, Georgia is required to provide comprehensive services and furnish all Medicaid coverable, appropriate, and medically necessary services needed to correct and ameliorate health conditions for children. This means even if a service is not funded through the state plan but deemed medically necessary, DCH is required to provide those services. We were unable to meet with representatives of Georgia's EPSDT office. However, several stakeholders we interviewed mentioned the benefits of expanding EPSDT services and informing pediatricians on the potential use of these services. Exploring how families can access supports through EPSDT is an important consideration for future research. As a final note, private insurance was not addressed through the scope of this study, but was listed as an avenue for further research as well. The school system's role is to provide education to individuals and remove any barriers that could impede their learning. The Georgia Department of Education is the state-level agency that provides leadership and service to local school systems and sets policies and recommendations for best practice to support children with disabilities. The local school districts are responsible for implementing policy and can lead to variation in service provision and support throughout the state. Part of the issue surrounding services for individuals with a developmental disability and behavioral health diagnosis comes from a shifting of responsibility between the school system and service providers. One of our findings was that some local school districts are reluctant to make recommendations for community supports for fear that they will have to pay for these services independently. While local education agencies are required to remove barriers to education, their responsibility is not to provide holistic treatment. It was found that service providers often consider the school systems to be the primary deliverer of services for individuals with developmental disabilities before the age of 22. While many services are provided through schools, and the school setting provides a consistent environment to assist children with special needs, additional supports need to be provided to supplement school-based services. The need for communication and coordination between the Department of Education, local districts, who exert a great deal of control around the Department of Behavioral Health and Developmental Disabilities, became evident through stakeholder interviews. Additionally, exploring the role of the Georgia Network for Education and Therapeutic Supports Program, GNETS, that provides intensive services for children with special needs with an alternative school setting, needs to be further evaluated. We received multiple perspectives about the role of GNETs, including discussions with State Department of Education personnel and direct service providers, and the role for GNETs in meeting the needs of this population. The 1963 Developmental Disabilities Bill of Rights and Assistance Act, also known as the DD Act, creates funding for states as well as public and nonprofit agencies. The purpose of this act is to ensure that individuals with developmental disabilities and their families participate in the design of and have access to needed community services, individualized supports, and other forms of assistance that promote self-determination, independence, productivity, and integration and inclusion in all facets of community life through culturally competent programs. In Georgia, the lead agencies are the Georgia Council of Developmental Disabilities, GCDD, the Georgia Advocacy Office, GAO, the Center for Leadership and Disability, CLD, at Georgia State University, and the Institute on Human Development and Disability, IHDD, at the University of Georgia. Each agency provides a unique role in caring for the rights of individuals with disabilities to lead fulfilling lives. Other service providers are shown here to represent the many organizations that provide support services. Looking for models of coordination for children in Georgia, we began hearing about the local interagency planning teams, LIPTs. These teams provide an infrastructure to coordinate services for children with severe emotional disorders and addictive diseases and their families. The Division of Family and Children's Services, DFACS, the Department of Juvenile Justice, DJJ, Georgia Vocational Rehabilitation Agency, GVRA, Department of Public Health, DPH, mental health providers, and the local school systems are all represented in these teams. The local interagency planning teams are an avenue to decrease fragmentation and duplication of services and maximize the utilization of all available resources in providing needed services. The limitation, as you can see here, is that this model is housed exclusively within the Behavioral Health Division of the Department of Behavioral Health and Developmental Disabilities, and does not include the Division of Developmental Disabilities, often creating a barrier for children with both a developmental disability and behavioral health diagnosis to be served under this collaborative planning effort. The Interagency Directors Team, IDT, was created to design, manage, facilitate, and implement an integrated approach for a child and adolescent system of care that informs policy and practice and shares resources and funding. The IDT is made up of over 20 representatives from state agencies and non-governmental organizations that serve children with behavioral health needs, many of whom are not captured in our visual. Similar to that of the local interagency planning teams, This program does not include the Division of Developmental Disabilities. Should better collaboration be sought, IDT has a potential to better serve children in Georgia. Here we see the impact that each level in our ecological system has on a child and their family. If looking from this perspective seems overwhelming, remember this is representative of the systems that a family must interact with to identify and access services for their child. The immense amount of information a family must collect and the often negative results that occur before a family can receive services in Georgia is a harsh reality. In Georgia, there's already an infrastructure in place, with many components of the system of care model available. Such components include different departments and divisions that provide an array of services to support children with multiple diagnoses and disabilities and their families. There are also evidence-informed models and frameworks that serve children with behavioral health diagnoses and developmental disabilities in Georgia that have been discussed earlier. A major component of the infrastructure includes public school education. Public school systems are mandated to provide special education services and support to children with disabilities and their families until the age of 22. Lastly, service providers and key stakeholders are ready and willing to provide the necessary supports and services that are needed for children with a behavioral health diagnosis and developmental disability and their families. Although there are components of a system of care already in place, there are significant challenges and barriers that interrupt comprehensive, coordinated, and cost-effective care to children with both behavioral health diagnosis and a developmental disability in their families. At the time of our study, lack of communication between staff and divisions, as well as the lack of collaboration between state departments, greatly affected service delivery. Inadequate communication and collaboration allow for systems of care to become easily disjointed, resulting in siloed services and uncoordinated care. In addition to the lack of collaboration, funding is another challenge and barrier to services and resources for both service providers and families. While there are numerous services within the Medicaid state plan, there is not enough funding available. There are long waiting lists to receive waivers, and there is unequal distribution of resources between rural and urban counties. In addition to the long waiting list, another barrier to access to services included Medicaid reimbursement. Many service providers stated that Medicaid does not cover the quality of care and cost of providing the services needed by children with a behavioral health diagnosis and a developmental disability. One last important finding by informants included the need for data on children with a behavioral health diagnosis and a developmental disability. Much of this issue is caused by the inconsistent definitions and diagnoses related to having both a developmental disability and a behavioral health diagnosis. The definition, diagnosis, and eligibility criteria changes between the federal and state levels. It is often difficult for families to receive coordinated care, which results in more crisis and emergency situations and increased costs. Our research shows out that race, class, and geographic location were major to disparities in services, resources, and information available. We also observed that a wider variety of resources were available to children and their families who reside in metropolitan areas relative to rural areas. Our work uncovered opportunities for the creation of a system of care that would involve multiple layers of an existing service network to serve children and adolescents with both a developmental disability and a behavioral health diagnosis and their families, with a family-centered and community-based approach. The 5 distinct groups we identified as critical to achieving a unified system are family, state agencies, service providers, schools, and advocacy groups. The complete list of recommendations is available in a summary report available on our website. Included among the solutions that would help families directly are increased services in rural areas. Families also need assistance with preparing for their child's IEP meetings and may also need someone to attend the meeting with them to provide knowledgeable support to ensure that the appropriate education, services, and supports will be provided based on the child's combined developmental disability and behavioral health diagnosis. As we stated earlier, raising a child with both a developmental disability and a behavioral health diagnosis can be expensive and overwhelming to families, resulting in a negative impact on income. Families should be able to access a combination of financial resources from government programs, private and nonprofit organizations, and family grant opportunities. We encountered a persistent need for integration of services throughout this study. As a state, we are rich in ideas and dedication. Positive change can occur in Georgia starting now with only slight modifications in the current system. Some inexpensive yet effective steps that can be done with minimal commitment of resources include: develop collaborative county-based planning for individuals with developmental disability and behavioral health diagnosis, train direct care professionals and staff working with people with developmental disabilities and behavioral health diagnosis, develop a continuum of crisis response services to prevent the need for crisis intervention and allow individuals to access services, increase family and other caregiver education and support, coordinate community-level services that provide assessment, medical, and dental care, integrated mental health treatment, guidance on at-home behavioral support, and training for the workforce. The time is now for us to work collectively as a state to be more responsive to the needs of children like Roy and the Shackelford family. We have a responsibility to make services and supports available and accessible regardless of where you live in the state. Stakeholders from every level of the system should build on the current strengths and work collectively to communicate more effectively and be a resource to children and their families. Barriers such as funding, eligibility criteria, and gaps in data should be removed so that families are not caught in a web of bureaucracy to receive the help that they need. The work that each and every one of us do should be guided to make the system of care more responsive and effective for children like Roy and his family. The 2013-2014 Georgia LEND cohort would like to thank the following family members for sharing their journeys and helping to inform this project: Monica Andrews, LaShonda Hurd, Christina Jones, and Deanna Shackelford. These families' stories of success and challenge were one source of motivation for us to contribute to building a more responsive system for kids with developmental disabilities and behavioral health diagnoses in Georgia. The members of the Georgia LEND cohort would not have completed this webinar without the assistance of many dedicated people and organizations throughout Georgia. The project team would like to offer a word of thanks to the Center for Leadership and Disability at Georgia State University, Creative Community Solutions, Developmental Pediatrics